My name is Tessa Cook. I'd like to tell you about our experiences at the University of Pennsylvania with CT radiation dose monitoring. There are two principles of radiation safety. First is justification. In other words, the patient should benefit from the exposure to ionizing radiation as part of the imaging procedure, and that benefit should outweigh the risk of the exposure. The second principle is dose optimization, and this is often referenced as ALARA, or as low as reasonably achievable. But it encompasses more than just the lowest possible radiation dose. Dose optimization really represents the fact that the examination should be tailored to the patient. In other words, to answer the clinical question, to be appropriate for the patient's size, and for the anatomy that's being imaged. It also reflects proper equipment maintenance and testing. In September of 2011, the Joint Commission issued Sentinel Event Alert 47 on the risks of radiation and diagnostic imaging. This event alert acknowledged the fact that while ionizing radiation is a valuable component in the healthcare process, it does have the potential to cause harm to the patient and therefore should be carefully monitored. The California state legislation, which took effect in July of 2012, recommends that radiation dose parameters be monitored and also requires that they be included in the radiologist's interpretation of a study. More recently, a similar legislation in the state of Texas requires radiation dose monitoring and reporting, and also formation of a committee that's responsible for radiation safety issues and issues related to imaging-related radiation. Historically, there have been significant challenges in the dose monitoring effort. The largest of these challenges was really the way that the data was stored. Dose-related parameters, rather than being stored as structured data that was accessible, were stored as pixels on an image-based dose sheet. And this made large-scale dose monitoring very challenging. More recently, vendors have adopted the Radiation Dose Structured Report, or the RDSR, which makes these parameters more easily accessible in a structured format for large-scale dose monitoring. It's important also to remember that when we refer to dose, we're referring to the radiation exposure of a cylindrical phantom, and not the actual radiation dose received by an individual patient. More work remains to be done to determine which parameters, or which new parameters or measurements, are more accurate representations of true patient dose. In order to facilitate radiation dose monitoring, we at the University of Pennsylvania developed Radiance, which is a freely available open source software for CT dose monitoring. Radiance is able to take dose parameters from the image-based dose sheet, from the newer radiation dose structure report, and even from the DICOM study header. All of this data is validated and parsed and inserted into a central database. At the University of Pennsylvania, we also access the Radiology Information System to pull additional information about the patient and the particular examination. This gives a comprehensive database which can then be used for a variety of dose analytics operations, everything from routine dose monitoring on a daily basis to generation of monthly reports, which we call scorecards, to detection of outliers, and participation in regional and national registries, such as the American College of Radiology's Dose Index Registry. Our radiation dose reduction efforts have really been multiple, not only with radiation dose monitoring, but also extensive protocol review and revision and subsequent modification, hands-on protocoling of CT examinations when appropriate, significantly increased education of residents, fellows, and technologists regarding CT radiation dose considerations and appropriate protocoling, and newer technologies such as high-pitched imaging or iterative reconstruction. A combination of all of these various efforts have resulted in some of the impact of dose monitoring that I'll share with you now. What follows is a subset of examples of how using the data extracted using Radiance and implementing a variety of protocol modifications has allowed us to image patients using less ionizing radiation. I'll show you examples from our thoracic CTs, abdominal CTs, and cardiovascular CTs. We first tackled the thoracic CT protocols. We looked at the old parameters for 3 categories of chest CT examinations: a high-resolution CT protocol, a routine unenhanced and enhanced CT protocol, and a pulmonary embolism protocol. We made particular modifications related to some of the dose parameters, which are shown here, to increase the pitch, decrease the tube current, and in some cases also decrease the tube voltage, such that diagnostic image quality was preserved even though less radiation was now used to image the patients. We tried to make these protocol modifications and parameter modifications more aligned with patient size, and also eliminated additional imaging sequences when it was felt that they would not add diagnostic information to the study. In looking at the dose parameters for before and after the protocol modification, we saw about a 33% reduction in the amount of radiation that we used for the unenhanced and enhanced chest CTs, as well as for the pulmonary embolism CTs. We saw a more dramatic reduction in the amount of radiation that was used in the high-resolution chest CTs. In particular, this was because one of the phases of imaging was felt to be optional in certain patients. If it was deemed medically necessary, either by the referring pulmonologist or the protocoling radiologist, that there be inspiratory and expiratory phase imaging, both phases were done. However, patients that didn't need the second expiratory phase were saved a second exposure to ionizing radiation. We also reviewed the number of studies in each category before and after the protocol modification, just to make sure that there wasn't any statistical bias introduced by having significantly fewer patients in the post-intervention group, and this was not found to be the case. This slide shows you some sample image data from the studies acquired with the old protocol and then with the new subsequent protocol. The top row shows images with the original protocol, the bottom row with the new protocols, and each pair of images is from the same patient who came for an imaging study at 2 different times. In all 3 cases, I've tried to match the anatomic location for the best comparison. This first pair of images is from the enhanced chest CT, and you can see that the patient had progression of metastatic disease between the earlier study on top and the subsequent study on the bottom, but that diagnostic image quality is preserved. In this unenhanced chest CT, there's a similar appearance. There's perhaps slightly more noise in the newer, lower dose study, but much of the imaging texture is preserved. And finally, in this high-resolution chest CT, which has been used on multiple occasions to follow up this unusual appearing nodule in the right upper lobe, again, there may be slightly higher noise in the lower set of images, but there is more than enough diagnostic information. So in looking at our high-resolution chest CTs, one of the benefits of this intervention was that the study was tailored to the clinical question in order to achieve dose reduction. So in looking at the study dose length product, you can see a significant drop between January and February of 2011 in the average study DLP, partly related to the optional expiratory phase, but also partly related to the reduction in the MA that was used. And this was an effort led by 2 of our thoracic radiologists, Drs. Warren Gechter and Eduardo Barbosa. The pulmonary embolism chest CTs were also similarly modified and again tailored now to the patient. KVP was adjusted to be more aligned with patient size so that our smaller patients could be scanned with 100 KVP or in some cases even 80 KVP. Our CT urograms, which are historically high-dose examinations, were also reviewed. And this was an effort led by our modality chief of CT, Dr. Susan Hilton. So you can see a significant reduction in total study DLP between May and June of 2011. And this was achieved in a multifactorial fashion. Historically, these were always 3-phase studies: an unenhanced phase, a nephrographic phase, and an expiratory phase. In the new protocol, we combined the nephrographic and expiratory phases, instituted very strict scan lengths for each of the 2 phases, implemented a split bolus injection with compression bands to help to opacify the ureters, and achieved significantly less radiation exposure to our patients than with the prior protocol. Finally, we've always worked with dose reduction in coronary CTA. One of the advantages of technological innovation in this area is that we now have 3 different acquisition options. In patients of the appropriate body habitus who have a low heart rate, we can do prospectively triggered high-pitched helical imaging. If the heart rate is higher than the optimal range or the patient is slightly larger than the optimal size, we can do prospectively triggered axial imaging. And we also always have the option of retrospectively gated imaging. However, this results in a higher radiation exposure than the other 2 options. We always institute strict scan regions for the unenhanced calcium scoring series as well as the angiography. And the KVP is tailored to patient size so that we are actually able to do 80 KVP imaging in our thinnest patients with the optimal heart rate. In all cases, we use tube heart modulation as well. This scatter plot shows you the total study DLPs for coronary CT angiography exams performed within the last 6.5 years. And you can see a significant downward trend, particularly in the last couple of years after the installation of our newest CT scanner with a number of sophisticated features to allow us to do even lower dose imaging. At the end of the day, a successful dose reduction program really begins with the ability to monitor dose parameters. And we have the good fortune now that there are multiple commercial and freely available options for radiation dose monitoring. Having access to the data is just the first step. You have to review the dose parameters, identify areas for improvement, and then develop a dose reduction intervention, implement that intervention, and then continue the dose monitoring process. So this really is a continuous cycle of improvement and review such that parameter modifications, the effective parameter modifications can be understood and adjusted in order to achieve decreased radiation exposures to patients. Now that's not the only thing that we can do. Participation in regional and national registries to contribute to the development of dose diagnostic reference levels is very important. Implementing regular review of dose-related parameters, continuing that cycle of review and improvement is critical. And supporting patients' abilities not only to track their exposure to medical radiation, to know what studies they've had and what types of studies they've had and when those were performed, but also giving them access to the imaging data so that that can be shared with their appropriate physicians rather than repeating the imaging is also a very important piece of this. And ultimately, what we all should be doing is working towards dose reduction with preservation of diagnostic image quality. I've included some references here to some of the information mentioned in this presentation, and I'd like to acknowledge a number of individuals throughout the University of Pennsylvania health system that contributed to the success of Radiance, as well as a number of our dose reduction efforts, and acknowledge my collaboration with individuals at the American College of Radiology, as well as with Dr. David Clooney. Thank you very much for your attention.